So we're going to move now to Jan. And Jan, we look forward to your thoughts on accreditation and the new professionalism.
Thank you very much for this. So thank you very much for having the opportunity to share some ideas with you on accreditation and the search for new professionalism. The objective of this talk is to try to define the professional profile that will be needed in healthcare and welfare in the future in order to respond to societal change. And we will do that from an exercise that we did in the Strategic Advisory Board for Health, Welfare and Family in the Flemish region of Belgium. We there thought together about new professionalism in care and support as a task for the future, and the report was made by Barbara Krekels and myself, and the chair of that Strategic Advisory Board. That board is composed of different societal actors that advise the Flemish government on a strategic level to prepare policy and to formulate policy visions at the long term. We do this on demand or on our own initiative. The council is composed by 28 stakeholders from the large civil society, suppliers, users of services, personnel in health and welfare and well-being and in family issues, but also socioeconomic organizations like trade unions, employers, federations, and so on. And moreover, there are some independent experts as well. So what we did, we tried to formulate what do we expect in the future of professionals concerning comprehensive care and support. And in second phase, then we want to try to see how we can realize this proposed vision. What do we expect of the labor market, of education and policy? So first of all, what we see is that the quality of life in our actual postmodern society is confronted with a lot of challenges. The demographical fact that we all get older brings also with that there is an increasing in chronic conditions. And in these chronic conditions, multimorbidity becomes more and more the rule rather than the exception. And that puts new challenges on the health system. There are important scientific and technological developments. Think about ICT, that has a lot of illustrations also in the field of healthcare. There is also in our society an increasing ethnic and cultural diversity. Think about the refugees coming into our countries, the way we deal with multicultural issues in healthcare. There is a clear economic trend towards greater competition. Market becomes the paradigm of all kinds of organization, of services as well. And there is also a change in the labor market with a request for more flexibility. It is clear that people want a new kind of integration between their professional lives and their lives in the private elements of their life. So that are the challenges we are faced with. And to this changes society, we have to answer. And the answer has to bring elements that can cope with the increasing complexity actually in the society. So looking for these answers, we first saw the analysis of what actually our way of answering to this complexity is. What we see is in the healthcare more and more specialization. We try to reduce the complexity by creating 30, 40 specialties in nursing, in medicine, and so on. Another way of answering this challenge is medicalization and therapeuticization. That is a kind of individual approach to societal problems. New diseases are coming up, new labels are formulated that try to solve problems by bringing them into the area of medicine and therapeutics. And the third kind of answer that we have is instrumentalization of the professional work, where objectives and resources are the basis for execution and billing. So those three answers, in our perspective, are not appropriate in order to deal with the complexity. What is needed is a comprehensive care and support that can contribute to more quality of life, because people want a 5-star quality life nowadays, and we have to find ways to deal with that. In order to do that, we want to get rid of the old concept of the patient, very much too passive. So we try to find new definitions, and actually we want to talk about a person with care needs and his or her immediate surroundings on the one hand, and the citizen on the other hand. That is what it is about. These are active people engaged in the care processes and active citizens participating in the way that the society is built, with a great attention to other societal systems than the care and the support, and also with a kind of territorial concept of citizenship, a story of civility. Starting from this terminology, we want to explore what quality of life today really means. When we do research and we ask people, especially people with chronic conditions, what really matters for them, then we see that two things are important. First of all, they want the best possible functioning of themselves as a person with care needs in the community. Functioning means to be able to go shopping, to participate in daily activities of life. But the second aim is they want to be an active member in the society. They want to participate in the society. They want to meet with friends. They want to have contacts with all kinds of people. And that are the two elements that mainly define actually for our population quality of life. And the Council then draws the attention on the fact that there are important existential and ecological components in this. It's about who am I in which kind of environment. This is the eco-bio-psycho-social model that we try to implement in daily practice. In the search for new answers, we think that when it comes to professionals, two elements are important. First of all, a more generalist approach is needed. That means that the change need should be addressed by a very broad generalist way of behaving, not immediately reducing problems in a specialty or subspecialty manner. And the second important thing in our society is that we see that connectedness becomes a precondition for autonomy. Autonomy is important, but autonomy can only be realized in connection with people, in connection with others, in connection with a neighborhood. What do we expect as a society today from this professional? Well, let's look at the different domains. First of all, the care and support professional. The core space of every health system is occupied by the unique encounter between one set of people, on the other hand, who need on the one hand, who need services, and on the other hand, professionals that can deliver those services. An essential component in this is trust. A trust that is earned between the care provider on the one hand and the one who needs care on the other hand. And this should be realized in a societal context with, as already Roger Sasa said, social accountability as an important criterion in order to assess the quality of the care and the support. That was a quote by the work of Julio Frank in the Health Professions for the 21st Century document produced by The Lancet in 2010. So that means that a professional needs both technical competencies and generalist competencies. And what are those generalist competencies? Well, we think as a council that those competencies are general that enable a professional to provide care and support based on a generalist strategy or approach. And what means that generalist approach? Well, this implies that a varied palette of approaches and strategies could be used to address a broad range of unspecified health and or well-being related problems. We use that as a definition of generalism, and we think that those generalist competencies should become increasingly important. So that does not mean that there is not a need for technical or specialist background, certainly, but apart from that, generalist competencies are essential in the context of comprehensive care and support. Some indications actually in debates that we have in healthcare that this is important. There is a need for new generalism. If we look at the Primary Healthcare Performance Initiative with the World Bank, WHO, and the recent report on improving quality primary healthcare, we see that this approach is absolutely needed. And also when we want to address social determinants of health, we need this kind of approach. The essence of the professional activity has 6 different fields. First of all, the quality of life as the aim for the care and the support relationship. Secondly, supporting self-care. Thirdly, sharing care and support with family caregivers. Fourth, strengthening social cohesion. Fifth, being sensitive to diversity and use technology and ICT in an appropriate way. With a focus on functioning, with paying attention to what really matters for people, strengthening participation and inclusion by informing, consult and support the autonomy of the individual, we can contribute to this aim. So this is a perspective that we should bring in, and that requires that the professional and the care institutions can be ready and prepared to give space for such an approach in the professional work. So the question is then, should we have a super professional, or does the future lie in working together? A lot of expectations. We don't want a super professional. The future lies in working together in cooperation, because that is the only solid answer to the challenges. So going back to the first question, our conclusion is accreditation processes could take advantage of reflection by societal stakeholders on new professionalism. This was one example, in order to guide the evaluation of social accountability and responsiveness to future challenges of institutions for health professional education.
Thank you, Jan. And I wanted to pick up on many of your comments related to generalism. And this is a bit of a provocative question. So just your personal thoughts on whether all medical specialist training should in some way be preceded by training in family medicine.
I don't think so, because that would be probably an inefficient way of dealing with the resources that we spend for education. That have being said, I think it is very important that the generalist approach is omnipresent in the undergraduate medical curriculum, that from the beginning of their career, students are trained in having this kind of generalist approach, that they are also exposed to where the generalist care is delivered, that's the primary healthcare level, in the communities, that they learn there how to approach problems, how to integrate health and welfare issues. And so that they are trained during their undergraduate training in having this kind of dimension. When it comes then to specialty training, well, one of the problems nowadays is that we train our specialists in silos. You have the College of Orthopedians, orthopedic surgeons, then you have the internists, you have the psychiatrists, and so on. And there is no connection between them. I think that also in postgraduate training, we need some transversality, some generalist dimensions, so that the future specialists are prepared to interact with each other in the framework of the increasing multimorbidity. They have to talk with each other. They have to take shared decisions all together with specialists and also between specialists, other healthcare providers, and the primary care level. And in order to prepare that, I think that also in the specialist training, there should be sufficient place for exposure to a generalist environment.
Great, thank you very, very much.